clarify, you didn't take into account, again, the fact that there are people with 100% state-funded mental health services that would now be eligible under expansion for main care, and some of that. I mean, you didn't look at that.
What I just said is that that particular program could be potentially covered now if the state wanted to cover those individuals. They do fall outside of normal Medicaid eligibility rules and limits right now, but if the state wanted to potentially petition Washington and ask them under a scenario, if they could cover those individuals, you could do that.
Get another waiver.
You could potentially, you could have a waiver, or potentially combine some populations, reduce the amount of waivers you have, and combine some of those populations so that you can include some of these vital services. So, I know.
But again, those assumptions. I mean, your report makes assumptions. Makes assumptions about FMAP, which I'm not going to say that I agree with. It makes assumptions about poverty rate, which are different than what other people who have been here for a long time make. But you didn't make any assumptions about other budgetary savings, such as mental health, HIV, corrections, and you didn't make any assumptions, regarding economic benefits.
Correct. Yeah. Correct. Now, for the economic benefits, I just wanted to talk a little bit about that. I had also taught economics for 17 years at a community college, and I did that part-time because I just wanted the student interaction. And I've seen a lot of consultants out there coming out with, economic benefits of creating a convention center or whatever. And I don't know how I can say this without being blunt almost, but it never happens. I mean, the
that never happens in this committee either.
Yeah, the committee, the economic consultant comes in. They say to some mayor or somebody who wants to build a convention center, look at all the economic benefits you get if you build it. They build the thing, they spend the money, and the benefits never come. And when we were looking at this, I was telling Gary, and we were talking about this. We don't want to do that. We don't want to start going out there and promising economic benefits that may never ever happen. And some of the other studies we looked at, in my opinion, they're irresponsible because they're making all these promises that are never going to come true. They're using these multiplier effects that most economists disagree with. But you know what? If you want to, if somebody really wants, to find a consultant that will give you that information, you can find someone. I mean, we just don't want to go down that road.
So as part of your work, have you looked at the actuarial study that the department submitted to CMS when it applied for the SIM grant and the $1 billion in savings that projected, including $400 million over time to the Medicaid program?
So happy to talk at a separate time about the Centers for Medicare and Medicaid Innovation and the structure and construct of the State Innovation Model grant. I think it is extremely separate and apart from and different. I understand what you are asking, but it is the degree of risk that you are willing to embrace in establishing certain assumptions and variables. What we wanted to understand is with some core variables and risk factors, what would that look like? We can certainly and have produced for you data around mental health and substance abuse spending and what that might mean if you assume that all of those individuals today that are benefiting from those programs and services that are 100% general funded, if they were on Medicaid. And those can be certainly part of your consideration. It does not discredit the magnitude and benefit of the report that's in front of you for the data that it presents around the financial implications for the state related to expansion and related to just growth generally in the Medicaid program based upon the baseline forecast.
So we have about 10 minutes. If you have a follow-up, that's fine. We have a list. We have Representative Sanderson, Representative Baer, and then Representative Stuckey next.
sorry. Not used to us being here today.
Thank you. I just kind of have a two-part question. Probably one is more for the commissioner, because she's more familiar with the historical outcome of our programs from the last expansion in 2002 that we did. We hear a lot about better outcomes, better health outcomes, reducing the rate of uninsured, reducing charity care for hospitals, etc. We know that the reduction in the rate of uninsured in Maine since 2002 to present has not been realized. It stayed very well flat, even with the last expansion, and also charity care has grown. But one thing that I guess I don't know is, have we achieved a better outcome, health outcomes for the individuals in the state since we expanded in the last one? That's the first question for Commissioner Mayhew, and then I'm just going to sit back and let everybody roll here. The second one is probably for you, Mr. Alexander, and you've had an opportunity to probably look at more states across the country than we have to see how their programs are, how the stability of their programs are at this time. And I guess based on what you've seen around the country with reforms in other states, where does Maine stack up? Is Maine ready to expand? Were these other states maybe more unstable? And do we need to do more here in our state before we even contemplate expansion? And if we expand now, what is the stability of our system, which is on shaky ground right now? What's that going to look like?
So I'm first. I'm not prepared, Representative Sanderson, to really comment on health outcomes. I think there's been a number of various studies on that front. It's important, though, when we compare the Medicaid population, to really be looking at perhaps comparing with the uninsured population in terms of health outcomes. I have concerns when you start looking at socioeconomic impact on health status. So individuals with chronic disease, when they're having surgery, are likely going to see different outcomes compared to a healthier population. What it speaks to, however, separate and apart from that, what it speaks to are the challenges that we face in the healthcare delivery system generally. And what we've been focused on in Maine and improving, as I mentioned before, the need to invest in primary care, in Medicaid specifically, the need to combine the medical and social model to do a better job of looking holistically at the individuals and families that we're serving, supporting more case management, more nurse care managers, which we've done through the health homes and the community care teams. It really, though, speaks to some of the other fragmented nature of the healthcare delivery system, the siloed approach to care delivery that Representative Gattin raised in identifying the SIM grant, the State Innovation Model Grant, and the work that we are hoping to advance through that effort to improve the healthcare delivery system and ultimately the outcomes for all of those who depend on the healthcare system. Gary?
Every state is different. It's not an apples to apples. What I would say is that it's obviously the legislature's choice whether you want to expand Medicaid or not expand Medicaid. But looking out at the horizon at different states, what I would say is that Maine is less prepared than other states from what this is only a personal perspective from what I have seen. So let me just give you a few examples. Let's look at Maryland, for example. Maryland has been very aggressive at looking at an all-payer system when it comes to Medicare spending, private health insurance, and Medicaid. And they've laid a lot of groundwork over the years as to how they're going to deal with the cost of growth. And in some respects, they've had some success. Whether we believe in a rate-setting system or not, Maryland seems to have done a decent job. They are expanding Medicaid. They would be, in my estimation, more prepared than a state like Maine. A state like Rhode Island. Rhode Island had a global waiver in 2009. The The state has successfully been managing that waiver. Their costs are very low. There's always something else to do in that state, or any state, but from the perspective of being ready to implement a huge new expansion, entitlement expansion, they would be more prepared than Maine. What I see of Maine right now is I see the commissioner is very hard at work trying to reform the system in Maine. It's a lot of work. These jobs, contrary to what anybody might think, these are extremely difficult positions. They're mentally taxing, physically taxing, and she's headed down the road pragmatically of looking at how to redesign Medicaid so that potentially maybe in the future there could be some sort of expansion or access of Medicaid. But I think right now, the way the state is approaching everything, it would be a tremendous burden on her in the department to give her another, yet something more to do, without globally looking at the system and saying, how can we as a legislature and executive branch come together to really design something so that we know we're prepared for the future? Something like a Maryland potential model, or something along those lines, where you're looking at an all-payer system, or you're looking at all of your pay or all of your funding sources together.
Thank you very much. Representative Baer.
Thank you, Senator. Good afternoon, sir. Sir, I just have a few questions, observations. I read the paper every morning. I hear the talk in the hall, and I'm going to take the perspective of the person in the street, the person who needs this expansion. And I think I join with a majority on this committee, in the House, and in Maine, in support of expanding Maine Care, and doing it in a way that has the least possible impact on the economy and on those who are already paying. And we certainly don't want able-bodied people who are, perhaps not as costly, but aren't impacting the ability to pay for those who are in critical acute care, as you point out, Commissioner. We don't want any of that. But when we have an economy where people can't pay, that's the problem. That's the problem we're trying to address. Trying to carry through with the philosophy that everyone who needs it ought to have health care. So my question with your report is, and it's probably accurate, I mean, the scenario you lay out is in my view, clear. I read it quickly. We just got it pretty much. But it's probably, it's a good read, but it does, advance a certain scenario, one that says we're going to get poorer, the economy's going to get worse. It could be the opposite, though. The economy could get better. We've got a pristine resource, both fish, traditional fish and timber. We have an educated population. We have less population growth. I do think that the costs are going to be there. We have an aging population. We have the oldest population in the United States per capita. I mean, that's a fact. So you stated that fact. Now, we just have to figure out how to pay for it. Have you considered what the solution is? My question is, what is the solution? Yes, you stated an $800 million or $1 billion, I think it's $800 million projection. How do we pay for that? How much do we increase taxes? What do we do about this number that you've given us? Have you considered that?
Let me address that. Really, that was not what we've asked in this report from the Alexander Group. You raised the very questions that we believe have to be part of the consideration. Now, what we have asked of the Alexander Group is to evaluate the types of flexibility that we might pursue with the federal government. That, as we've talked about in here, we're dealing with a federal Medicaid regulatory structure that is antiquated. It has not kept pace with the changing delivery of services. It has not allowed us to effectively support lower-cost, community-based settings as aggressively as we believe are important to support people in their homes and in their communities. If you could get that kind of broader flexibility, get out from under some of the siloed waivers, to be able to look at individuals more comprehensively related to their needs, and have a Medicaid program that could be more supportive, supporting more, as I said, community-based, home-based services. That might, as Gary said, we could begin to identify what does that create in the efficiencies in the program that might free up more resources to support expanding those who are able to access the program, like the disabled, like our children, who we know are going to need more substantial services in the future.
Thank you, Commissioner. You mentioned the high-end cost of 5% and 20% and then the rest. Would you agree, though, that this projection would be different if we shifted away from high-cost emergency room acute care type responses to meeting, to covering people in those scenarios, and go to more home-based, home health centers where there's a lot less cost per skilled service being provided for health care? I mean, I see it in the county. I see the visiting nurses of Aroostook County providing a nonprofit service, low cost. We're talking $10 an hour for CNAs to do the very same thing that more expensive hospitals are doing.
I am completely committed to the path that this program is on, the work that has been underway with providers, with consumers, with nonprofit agencies throughout the state that are about supporting more primary care services, the health homes, the community care teams. It is having an effect. Our emergency department initiative is having an effect. The high-cost individuals that I described earlier, the 5% of our main care members driving 55% of the spending, those are individuals who have extreme needs, both in terms of supports that they need for daily living. These are individuals in 24/7 residential facilities, highly complex medical needs. Those costs are going to continue. Now, we need to make sure that we're providing the right complement of services to all of those individuals, but those needs are going to continue, and that needs to be absolutely part of the projection.
Forgive me for interrupting. We are going to have the last question from Representative Stuckey, and just to balance our conversation, we have invited Jeff Austin from the Hospital Association and Sarah Gagnon-Holmes from Maine Equal Justice to come and comment after. So, Representative Stuckey.
Thank you, Madam Chair, for the pressure of the last question. I appreciate it.
It always happens.
There's been a lot of talk today about the cost of, to the state of Maine, and I guess I sit here and am distressed at the absence of any talk about the people of the state of Maine. And I think that there are 70,000 people that are part of this discussion that this report is about, and I wonder what's the cost to them. I also live in a community that I think prides itself in being a civil community. I think the state prides itself in having a civil society. So if there are folks who are without coverage because we don't expand the Medicare coverage, one, what happens to their health care? And two, aren't the costs of that care also costs to the state of Maine? And there are risk factors in not providing the coverage. I was distressed earlier about the connection between, or the sort of competition between disenfranchised and underfunded populations, when in fact the state budget, after all, has a much broader scope than that. It also has a revenue side to it. And there are plenty of ways to find resources if the state of Maine deems they are important enough. So I guess my question to you is as I'm sitting here on the Health and Human Services Committee of the Maine State Legislature, responsible for providing some oversight and direction to our colleagues in the rest of the legislature about how we think we can best care for the folks in the state of Maine. What happens to the folks who don't get the coverage? If we don't expand, what happens to them? How does that get paid for? And how do we work that into the equation as we try to balance what's best for the state of Maine?
Well, I'm going to answer that. I want to be crystal clear. That is exactly what we are focused on, are the people that depend on this program today. I am fielding, as are you, the panicked calls from parents whose children are about to graduate from school, who have intellectual and developmental disabilities, that are scared to death about what services are going to be available to their children, and that is the role the Medicaid program absolutely should be focused on.
No,
Well,
Commissioner, I understand that.
No,
There are also calls.
Representative Stuckey, I am equally passionate about how we serve well the people of this state. And when I look at the decisions I am having to make regarding elderly and their access to needed services, we do not fund those services well today. So I am sorry. I've also been here long enough to see that we don't bring adequate resources to the table or are willing to make tough decisions about how we need to prioritize those services.
Yeah, you're missing my point, Commissioner. Well, my point is that it's not necessary to force the competition between the phone calls you get from those folks who are not able to access services and the phone calls you also probably get from people who are about to lose services.
So we're not going to have a debate here, I think. I'm going to have the last question, and it's very easy, yes or no. And that is, for other reports that we got from the Kaiser Foundation and from the Maine Heritage Policy Center, why is your report so very different than the outcomes of their reports for the expansion?
In terms of the cost?
In terms of the cost and the value and the jobs and or any other piece.
Okay, so when it comes to cost and enrollment, our numbers were based on what we received from the department, based on the risk factors that we deployed into the equation. I don't know that Kaiser used those types of risk adjusters. They probably didn't. We had to, because there is a reality that poverty is increasing. There is a reality that people will drop their coverage, and there is a reality that per member per month costs will continue to increase. So we could have pulled those out of the report and just followed a baseline analysis, but it wouldn't have given you where the state is trending. In addition to that, we only looked at the empirical numbers that we had in front of us. So, for example, the federal money coming from Washington, how much will Maine get? We can't estimate that the economy might improve simply because we want to estimate that. We only can look at what has happened historically and base it on that. So I can't speak to their report. When it comes to the jobs numbers and economic impact, it's almost the same as looking at emergency room utilization. It's very hard from an actuarial perspective to tease out those numbers and make them accurate because we don't know